Yes, sir.
First of all, I'd like to congratulate both Vidushi and Suresh for such an excellent course which they've been doing for so many years, of which I've been a part of, and Jagat and Harshal for their excellent knowledge which they bring on the table also. So since Jagat showed another type of management, I thought the same type I'll take a bad subluxated coloboma type of lens. Look at the problem in these cases. There is a large white to white generally in these cases. These are like Marfans, etc. What we do is we have gone vertical. That means we are making your flaps at 12 o'clock and 6 o'clock because we see which is the shortest distance available. Generally, it could be vertical. And Jeevan Ladi from Pune actually explained to me this, and since then I've been using this vertical glued IOL. So wherever the flaps are, you have to sit exactly 90 degrees from that. So now see, I've rotated the patient. That means the flaps now have become horizontal, though it was 12 to 6. The advantage is you will understand when I do the handshake technique, then only it can work. Now I made my infusion cannula inside. Now, a small trick which I want to tell everyone and the delegates here is, when you have these large eyes, do a small iridectomy. Watch what I'm doing here. A small peripheral iridectomy in the area of the scleral flaps on either side. The advantage in this game is, I can come now anteriorly, about 0.5 millimeter from the limbus even if needed, and go through the iridectomy. So I do not damage the iris. You see that sclerotomy now gone inside. Now I'm very safe. Once you have done that, you can also do your vitrectomy, lensectomy through the same incision. And you can do this like nibbling a rat eating a piece of cheese. Now remember one thing, I don't need this capsule at all. All it will do is give me more distortions. These are progressive disorders. That is why I don't tend to do any of those rings or segments, because I feel these cases will be better off with the glued IOL technique. But then everyone has their own preferences, which is fine. That's what science is all about. Once you have removed the whole lens, now I extend my incision. Now watch, I've taken my 3-piece IOL, passed it inside the eye. Watch the haptic. It's a little bit outside the cartridge. Go in through the glued IOL forceps, catch the haptic. Once the haptic is caught there, now ask your injector assistant to inject. Wait for it to unroll and unfold. Once it has unfolded, now I externalize the first haptic. Don't externalize till the whole lens has come out. Now watch the handshake technique, and that's why I told you I rotated the patient. Now I pass it from one hand to the other. This is the no assistant technique which was started by Dr. Narang. And here you see I've transferred it from one hand to the other. Go back through the side port again, through the sclerotomy here, catch the tip of the haptic and pull it out. And that is game, set, and match. And you can see there, both haptics there. Watch carefully the amount of haptic externalized. I told you it's a more than a 12 millimeter eye. That's a 13 millimeter lens, but look at the amount of haptic externalized because I came anteriorly, and that is the importance of this peripheral iridectomy. Now the rest of the procedure is very simple, which you all know about. All you need to do is create the Gabor-Chariot's pocket with a 26 gauge needle, tuck the haptics inside, as you can see there what I'm doing now. If both sides are tucked, all you need to do is see whether the lens is centered or not. One more thing you need to do is, if you come anteriorly, remember, you got to check whether there is an optic capture. How do you check it? You can always inject some air inside, and if there is some optic capture, it will happen. If not, you can leave it alone. But if there is optic capture, very simple, do a single pass 4-throw pupilloplasty. In this case, you can see there is no optic capture present at all, and the patient is very simple. All I need to do now is just apply the glue and seal the case down. So this basically completes this first case, which I thought I'll show you about. And once I've done that, I'll just move on to the second case for time shortage. And I thought I'll take another difficult case here. In this case, particularly when we are doing the phacoemulsification, you will see what's happening here. In this patient, as we are operating this patient, this is called the triumvirate technique. Now, when we started the phaco, you can notice when we are doing the phaco, there is a PCR, and with the PCR, there's a vitreous loss. Now, you obviously have a PC rupture, you have got vitreous loss, but more important is you also have a nucleus still in the eye. So this is the problem which you're facing. Now watch, this is the trocar AC maintainer which we designed. It goes 0.5 millimeter from the limbus, but it goes above the iris. See, I can't see inside. So this, I know, I can see it very clearly. I know the fluid will never go into any subretinal space. There's no question there. I now make my flaps. So I've got my fluid going inside the eye. Now I make my sclerotomies, 1 millimeter behind the limbus, as you can see here. Once I have done that, remember the terminology which we used was the triumvirate technique. That means there are basically 3 techniques here. First is the PAL. So we are using the modified PAL, and we published all this in the JCRS, in which I'm bringing the nucleus anteriorly. I'm doing vitrectomy also so that there is no vitreous present when I'm going to inject my IOL. While I'm doing that, I will also knock off my cortex or anything lying inside. Now, once vitreous is gone, I move to the second portion of the triumvirate. I'm going to inject my IOL. All you do is be careful, inject the IOL above the iris, but behind the nucleus. So you can see the first haptic has gone inside. Now my second haptic has gone inside. Basically, the IOL has blocked the pupil. Now, I have created my own posterior capsule. I have created the IOL scaffold. Now what we need to do is very simple. Use the phacoemulsification and emulsify the pieces. Remember, I've got an air pump on. So I've got a very deep chamber. So do not worry about endothelial damage, because it will not happen, because my chamber is quite deep because of the air pump always being on. Once that's done, all I need to do is remove cortex, and the cortex can be easily removed with the vitrectomy probe. So the problem is always the nucleus. Now dilate. Use iris hooks. I did not dilate before because I did not want the nucleus to fall down. Once my nucleus is gone, I am safe. So all I need to do is now take off my all cortex, etc., and remove all the peripheral areas. When you have done this dilatation with iris hooks, I like iris hooks because they're very safe comparatively and very easy also to use, but you can use any device of your choice. Once you have done that, then you can check and assess whether you have capsule or not. If you have capsule, put it into the bag, put it into the sulcus, game is your choice. But I always suggest to put a 3-piece IOL, because then if you don't have capsule, you can always convert to a glued IOL. So now what I'm doing is doing to the third part of the triumvirate, which is the glued IOL. So I'm going to now do the handshake technique, transferring the haptic from one hand to the other. Once I've caught the tip, I'll do the vitrectomy again to clear all this muck which you are seeing there, so that things are much safer there. In other words, the PC IOL in the AC is now converted to a PC IOL in the PC using the handshake technique. Again, second haptic externalized using the handshake technique again. Both haptics are out. Take out the iris hooks. Now all you need to do here now is tuck your haptics inside. Again, check, do you have any optic capture? If you don't have, well and good. But if you have, please on spot do the single pass photoretinoplasty, because you don't want the patient to come back again to you to the OR again for doing the pupilloplasty. Here you can see I'm just checking whether I have any problem here of any vitreous in the AC, anything. So ocularly you can check with triamcinolone, check everything there and see if everything is all right or not. And once things are all right and you see I don't have any optic capture because I've injected some intraocular pilocarpine also, I'm much safer now, and this patient looks pretty okay now. All I need to do is apply the glue and seal the case down. So basically what I thought I'll show you is these two cases. One, I showed you the coloboma. The second, I showed you basically a case which was the triumvirate technique. And nice seeing you, Ram, also. So basically, Suresh, I want to thank you once again for inviting me for this lovely course of yours.
Thank you, Dr. Amar. You can show third case if you wish, we have time.
Okay, then I'll do it just now. Then I'll have to share again. 1 second.
Sure.
Just a second. Okay, so since he's asked me to show another interesting case, I thought I'll show you this one. Okay, because he wanted me to cover up subluxations there. Yes. And subluxations again are a tricky situation to handle. So look at this case now. This is the intraoperative view, you're seeing a massive amount of subluxation. Now, when you have a subluxation of this size, if it is a progressive, I will go straight for glutathione. But if it is, let's say, traumatic or not a progressive type, we have this other alternative. And to be honest to you, this was started by Dr. Susan Jacob. Here you can see I'm fixing my rexus there. The flap has been made exactly opposite the maximum area of the subluxation. Now you see I'm making an incision, a sclerotomy from that side. Now this is the glued capsular hook. Now this is a paper clip now, which is a better modification of it, where the capsular hook works like a paper clip. You can see I pulled it out there through the sclerotomy. Now this works like a paper clip. So all you need to do is made of PMMA, and it locks onto the rexus margin. So it's a very safe procedure, very simple procedure, and can be used by anybody there. Morture is making this, and I have no financial interest in this when I'm talking on it, but that's the basic dimension of it. Here you can see now, once I've got my paper clip fixed there, I'm also using these capsular hooks to get better stability. These side capsular hooks will be removed. The one which is the center, which I'm showing you now on an animation, is this the way it locks inside the capsular bag there, will not be removed and will remain permanently. The advantage here is, here I can tuck it inside. So I can keep on pulling to as much I want. The problem when you do in a suture is, if you pull it too tight or too loose, then to redo it is a problem. Here, how much ever you tuck, it's in your hand only. So here you can see there, now the bag is very stable. All the rest of the procedure becomes very simple, because once your bag is intact there, all I need to do is take off my nucleus. Remember, I always use an air pump in all my phaco cases. So my chamber is quite deep always. Here you can see the nucleus gone. Now, once you have got that radial fixed, I want to give it a circumferential fixation also. So I'm using this endocapsule ring, which will give it a permanent circumferential fixation also. Now all I do is remove the cortex and implant any lens of your choice. The lens can be of your choice, because now you have actually, frankly, a whole bag of your, like a normal bag complete. These capsular hooks are removed. You can use iris hooks. The problem in iris hooks in this technique is it can rip open the rexus margins. So if you don't have capsular hooks, you can use the iris hook, but be careful that they don't rip open the capsular bags. Now you can see that's how the end case looks when the case is completed there. I've done some stromal hydration, better to put a suture there. Now all I need to do is apply the glue on the scleral flap and seal that down. And that's how the case looks when it is completed. Now you can see this is the post-operative day one of this patient. The patient immediately is 2020. So this is the glued capsular hook, which I thought I'll talk to you about. And you can see we had published this in the JCRS. And to be honest to you, this is Susan's innovation, not mine. So I have to give her full credit for working on this. So I thought I'll show you this also. Thank you very much.